to introduce us all to those problems.
Thank you, Tony, and thank you for inviting me again to speak here. So the next 40 minutes or so will be about memory problems which are not dementia, and where do we go from there? So it's really a whistle-stop tour of when you are actually seeing people, what are the differentials we need to think about and consider when we are doing an assessment. I'm happy to answer questions afterwards if you want to put up questions on the chat box, or if you want to interrupt me, that's also fine. But I think because of the echoing, it's probably better to ask questions at the end. Lisa, did you have a question? Your hand is up. I'm presuming that's a no.
I'm assuming that means that Lisa and Dawn, Lisa and Dawn haven't put their hands down when they come back. But Lisa, I don't know, did you have a question, Lisa?
No, sorry.
No, it's okay. If you put your hand down, we won't have to put you on the spot again. That's great. Okay, Shami.
Yes, thank you. If we can go to the next slide, Tara. So what are the differentials, or what are the other diagnoses that can cause memory impairment that is not a dementia? We need to certainly consider primary psychiatric disorders like bipolar, depression, schizophrenia. There is the all-new concept of functional memory disorder or functional cognitive disorder. We need to think of alcohol-related brain damage, alcohol-related cognitive impairment. We need to think about what effects medication have, the anticholinergic burden, epilepsy and the meds which can cause problems. And of course, there is the concept of brain fog and COVID-19, long COVID. There is a lot of research coming out about memory issues, cognitive issues, and it's really waiting and watching how things really evolve on that. Next slide, please. So the cognitive impairment which can occur with primary psychiatric disorders. So the primary psychiatric disorders are bipolar, OCD, schizophrenia, depression. Next slide, please. And as you can see, different disorders affect different parts of the memory. So some may affect what is called working memory. So that's the amount of information that can be held in mind and used in execution of cognitive tasks. Some may affect episodic memory, which is a long-term memory that involves conscious recollection of previous experiences together with their context in time, place, and associated emotions. Some may affect visual memory, verbal memory. Processing speed may be affected. That's how long it takes to respond to and process information in one's environment. And of course, we know a lot of these primary disorders can actually have an effect on executive functioning. So for example, we see in bipolar disorder, there may be difficulties in visuospatial functioning. There may be moderate impairment in executive functioning, attention. There may be difficulties in working memory, verbal fluency. There's also research actually to show that bipolar patients in general with higher mean level of education show less impairment in working memory and other functions of executive dysfunctioning. A good example is schizophrenia. We often get people with long-term graduate schizophrenics who get referred to our clinics. and they score kind of 65, 66 on their ACE3, and then everybody's jumping up and down, oh, this person has a dementia. Now, schizophrenias, there are loads of studies investigating working memory deficits in schizophrenia, and they are linked to poorer functional outcomes. So just because somebody with long-term schizophrenia has scored 65 out of 100 on an ACE3 or a cognitive assessment actually does not mean that they have a memory disorder. So we need to be careful with people with primary psychiatric disorders and consider all these factors when we are actually assessing them for a memory impairment. We need to remember dementias are progressive conditions. So somebody with with a schizophrenia who scored 65 out of 100 on their ACE may have been like that for 10, 15 years. We don't know because we do a spot ACE, and we cannot show there is neurodegeneration or progressive degeneration. So be careful when you diagnose dementias in these group of patients. Next is the functional cognitive disorder. Next slide, please. And next slide, please. So this is a very important paper which talks about functional cognitive disorder as dementia's blind spot. What is functional cognitive disorder? Next slide, please. So these are people who have one or more symptoms of impaired cognitive functioning. But there is evidence of internal inconsistency, which means that at times they have the ability to perform a task well at certain times, but the same task they cannot do at other times, particularly when that task is a focus of attention. So in functional cognitive disorders, we have symptoms or deficits that are not better explained by another medical or psychiatric disorder. But these are symptoms that cause clinically significant distress and impairment in social, occupational, or other areas of functioning, and therefore warrants medical evaluation. Next slide, please. So we've already spoken about the internal inconsistency. So this is again where the people perform a task well at certain times, but do not do so at other times. So the individual components of the task required to execute the task are intact, but there may be difficulty in engaging them at the appropriate intensity or duration on demand. Tony spoke about MCI a bit earlier on. Next slide, please. So there is a lot of overlap between MCI, mild cognitive impairment, where there is objective cognitive decline greater than expected for age, which does not interfere with activities of daily living. There is also the subjective cognitive disorders, where there is a subjective concern regarding decline in cognitive abilities without evidence of that objective deficit. And probably a mix of both is, and having a bit of both is the functional cognitive disorder. So some of the clinical signs of functional cognitive disorder, if you see a patient, they are often attending alone. They are often able to provide detailed answers about previous memory failures and personal history. They respond appropriately to compound questions. They answer quickly. They answer loquaciously. You do not notice a word finding difficulty. You do not notice any hesitation when they're giving the answers. they do not turn their head to their companion if present when providing details. So they're not asking their companion for reassurance on what answers they are providing. Often the patient is more worried about the problem than their partner or their relative. And you will see that they are often referring back to answers they've given over the course of the interview, like saying, for example, as I said before. And there is almost what is called memory perfectionism, which is a frustration with lapses that others would consider relatively trivial. Next slide, please. In spite of all that, functional cognitive disorder is different. It is under-recognized. And the problems are with how the brain is working rather than actual loss of brain cells. That, however, does not say that these won't develop into a dementia at any point in time in future. So it is often difficult. And people with functional cognitive disorders are often troubled by their memory problems as much as other people. Even about 5-6 years ago, people used to say, so the research was that functional cognitive disorders get better over time. But as more and more research is coming into place, we now see that actually the memory problems may stay the same over time, come and go, or even get better, or can sometimes even get worse. So it doesn't mean that just because somebody has a functional cognitive disorder, it's not a problem and it's they are just going to get better. Just wanted to touch a bit on how to manage. I think it's a difficult one because giving a diagnosis in some ways is easy, but that person is still living with those memory problems. So explain to the patient might be useful to focus on the mechanism by which the symptoms arise and discuss maintaining factors. It's important to reassure neuroimaging, neuropsychometric results may or may not be helpful. Sometimes there might be a little bit of change in neuropsychiatric testing. Sometimes there might be a little bit of change on scans. And that kind of an incidental finding may actually reinforce the patient's view of memory conditions. There is some psychological therapies available called expectancy modification change, which aims to alter patients' belief and attitudes about their own memory through combinations in cognitive restructuring, in educating them, psychoeducation about normal memory processes and aging, relationship between memory, stress, mood, and also stress management techniques. So just to conclude on functional cognitive disorders, it is a problem. It's important to remember that it is a problem to the patient. So let's not brush it off, but rather reassure the patient and see how we can help them. I think on a positive note, it's good. It's not a dementia. However, there is also no guarantees that it will not progress to a dementia in future. Next slide, please. I'm now going to touch on alcohol-related brain damage. This is something we see a lot of, and certainly the proportion of older people with substance misuse and alcohol misuse continues to rise, especially with the baby boomer generation. And I still think we often feel quite embarrassed to ask an older person how much alcohol they are consuming and what is the limit, and how it kind of affects cognitions, the use of excess alcohol. Next slide, please. There are different profiles of cognitive impairment. So some may not have any impairment. Some may have isolated executive problems with normal memory and globally cognitively efficient. Some may have mild executive dysfunction with memory impairment, and some may have global impairment. We talk about alcohol-related brain damage. It's a brain disorder caused by person regularly drinking. Next slide, please. Too much alcohol or binge drinking over a prolonged period of time, which causes vitamin B deficiency, causes toxic effect on nerve cells, and of course, when people are binge drinking or are drinking excessively, they are prone to head injuries, they are prone to blood vessel damage. The three main types of alcohol-related brain damage are Wernicke's encephalopathy, which is the triad, neurological disease, a triad of confusion, inability to coordinate voluntary movement, which is called ataxia, and eye abnormalities. Then there's Korsakoff syndrome, which is a chronic memory disorder caused by severe deficiency of thiamine. Korsakoff's is mainly caused by alcohol, but can be caused by some other things also. And of course, without treatment, cognitive impairment can grow worse and eventually developing into a lasting syndrome known as alcohol-related dementia. Cognitive deficits are made worse by malnutrition and especially by the deficiency of vitamin B. And again, this is common in our group. This is common in people who use excessive alcohol. They often don't eat properly. They often self-neglect, and that kind of compounds the situation. But the good news is that people actually can improve. And there are lots and lots of studies actually saying that if people can abstain for a year, minimally a year, the brain cells regenerate and the functions can come back. And the longer you are abstinent, the longer things can get better. So there is a positive note in that, and if people do present to services, we usually ask them to abstain for 6 months before we do cognitive testing. Some may be already in the stage of alcohol dementia, but people earlier on in this stages, the treatment is actually abstinence. Next slide, please. Where does the damage occur in excessive alcohol use? There is a lot of frontal lobe damage, the limbic system, hippocampus, mammillary bodies, and hypothalamus are susceptible to chronic excessive alcohol use and thiamine deficiency. This leads to Wernicke's and Korsakoff's. Cerebellum shows reduction in white matter volume, and connections between cerebellum and frontal lobe thalamus are all impaired. So really, you might find a lot of frontal lobe features in those who are drinking quite excessively. So there's sort of things which can happen with as a result of heavy drinking. There may be problems in processing speed. There will be problems in working memory, problem solving, spatial processing, impulsivity. So really a lot of frontal lobe symptoms can happen with excessive alcohol use. Next slide, please. There are lots of difficulties in diagnosing. People often do not present to us. People are unaware of what is the limit and what is excessive alcohol use. And we have seen people who have alcohol-related brain damage or Wernicke-Korsakoff's being diagnosed as Alzheimer's disease. There is no single assessment tool, and other screening tools may not be intended to give an accurate diagnosis. It's hard to distinguish between the long-term effects on the brain and the short-term effects of intoxication and withdrawal. Often very difficult to get an accurate history and collateral history to actually support the diagnosis. And like I said, people who are excessively using alcohol often have very little insight into their problems and may not seek help into their problems, and often come to the services through various other pathways. For example, social services may refer, or a friend or a neighbor might refer. And because of that lack of insight and that inability to understand the effects of alcohol on their brain, it is very difficult for them to stay abstinent, and therefore to kind of be assessed in an environment where there is no alcohol, and things might be drastically changed for the better if they are able to abstain, and there's a lot of research on that. Next slide, please. I'm sure all of you know about the CAGE questionnaire, maybe some basic questions to ask when you're doing a rapid screening. Asking about whether they should cut down, annoyed by others criticizing around your drinking, felt guilty about drinking, had an eye-opener, or rather felt the need to drink first thing in the morning. So the CAGE questionnaire is very common, and I don't see a reason why it shouldn't be used. Again, it's very important to know that for most people, the brain can heal if started in time. Abstinence from alcohol can reverse much of the physical damage caused by heavy drinking. I've said this before, the most noticeable improvement in cognitive function begins after 1 year of abstinence, and longer periods of abstinence actually result in greater improvements. And there is also research to show that MRI studies have shown that lost gray matter volume due to chronic alcohol use begins to regenerate in as little as 2 weeks of abstinence. So there is good news there in a way, if people can stay off excessive alcohol use. Next slide, please. Now we are going to talk about medicines. We know about anticholinergic burden. The use of anticholinergic medication is linked to cognitive issues and, of course, an increased risk of dementia. It's linked to increased rate of falls, decline in cognitive functioning, and lots of other things. The anticholinergic burden scale developed by Bustani et al. Is an important one, and I think it's something we can all use all the time. That includes medicines which have an negative effect on cognitions. Next slide, please. Most of our psychotropic medications are notorious for increasing anticholinergic burden. A score of 3 or more is considered clinically relevant, with 70% chance of 2 or more adverse effect. So as you can see, there's olanzapine, there's amitriptyline, there's clozapine, there's quetiapine, all actually straight away fall into the ACV3 score 3. Things to consider. A lot of patients who present to us have polypharmacy and are on a whole load of medication. So the starting point may be to ask by asking the GP, could we cut down some, could we bring some down, because that may have a positive effect on cognitions. Codeine is another one. A lot of our patients who come to us are on drugs like tramadol, codeine, morphine, and all of them have a deleterious effect on cognitions. Next slide, please. I'm just going to touch on brain fog. It's a type of cognitive dysfunction involving memory problems, lack of memory, mental clarity, poor concentration, inability to focus, and it can occur with a wide range of conditions like stress, lack of sleep, medications, various medical conditions, diet, hormonal changes. COVID-19, next slide, please. COVID-19, long COVID, there are ongoing research about cognitive issues, evidence of symptoms of exhaustion and mental fatigue, maybe encephalitis, lack of oxygen to brain, strokes in COVID-19 has caused some damage to the brain, which is why brain fog is quite common. Watch the space, really. I'm sure in years to come there'll be more on this. I wanted to cover epilepsy and memory. A lot of our patients come to memory service who have epilepsy and have a memory impairment. Is it a dementia? Is it not a dementia? It's a main contributor to poor quality of life. Factors that contribute to memory impairments are medication for epilepsy, underlying causes for seizures, psychosocial factors, and those who are having recurrent seizures. I think research has shown it's unclear if memory impairments remain stable over time, or do they worsen as seizures become more intractable. Anti-seizure medications, they can affect attention and concentration, which in turn could indirectly affect memory processing. Those on monotherapy has been shown to perform worse. However, some of the newer medications have fewer cognitive adverse effects. Medically refractory epilepsy on polytherapy there can be significant deleterious effect on attention, executive function, and memory. However, we need to remember this is not a dementia, and again, with MRI scans, even hippocampal volume loss has been correlated to verbal memory loss, and that has been seen in temporal lobe epilepsy. So there is a lot of overlap, and just because somebody has epilepsy and some memory issues, again, does not mean they have a dementia. There needs to be that progressive neurodegeneration to be able to show that that is a dementia. My last slide is on how to assess. It's important to get a detailed history. Again, past, present, primary psychiatric disorders, what treatments are the patient having for it, because remember, the primary psychiatric disorder may already have an effect on cognitions, and treatments which cause anticholinergic burden, may increase that risk of cognitive difficulties. Medical history, medication, previous treatments, alcohol use, other substance use, and of course, medications like pain relief, anticholinergic burden, and polypharmacy. I think often a collateral history is important. Of course, the cognitive testing is important, and cognitive testing basic cognitive testing like an ACE3 may or may not be helpful because there may be incidental finding, and therefore a detailed neuropsychological testing may be very helpful to make aware that cognitive impairments are different to in a dementia and a primary psychiatric diagnosis. It's important to assess the activities of daily living, what they are and what they are not able to do. MRI or CT scan of the brain may be normal or non-specific. Some may have diffuse white matter changes. Some may have age-related atrophy. Of course, the question is there a need for more specialized scans? Again, it depends, and it also depends on what access areas have to scans. I think that's all for diagnosing memory disorders. I've put in a list of papers, quite interesting to read. So if you can find them, have a read of the papers.
Brilliant. Thank you very much, Shami. If there are any issues or questions people want to raise, now is your chance. Put up your hand, and then we know you want to ask the question. Can I ask, Shami, just as far as alcohol, do you feel referring somebody with alcohol-related cognitive impairment is an appropriate referral to memory services, or not?
I think it depends. So if somebody is drinking very heavily, and some of the referrals we get are 50-60 units a week. And in those cases, we kind of say, we won't discharge you back, but come back to us in 3-4 months' time when you cut down. And we also try and ask SMS to help them to cut down. It then depends on what the outcomes are from that, because as we saw, research actually shows that if they have been abstinent, things can improve significantly. So that's a roundabout answer, but we don't always, it depends, I think.
No, I was asking you obviously to be provocative, because I think unfortunately alcohol-related problems seem to be becoming more common, perhaps because although we're told that the population as a whole are drinking less alcohol, but older people, the over 50s, are drinking more. And certainly, I think the problem is that they don't seem to fit into any particular services, and they end up slightly falling between different stalls. My feeling is, as Shami says, is your memory services, memory assessment services can't actually become sort of alcohol withdrawal services and supervise alcohol withdrawal. But equally, alcohol-related services may be good at managing the withdrawal, but perhaps they're less skilled and less knowledgeable at managing the cognitive problems. And perhaps it's what we need to do is actually perhaps working a bit more closely together. And the people who have successfully reduced their alcohol intake then they often are very motivated to actually cooperate with services having made that sort of big change, and will particularly help from sort of cognitive rehabilitation type approaches. And so that should be, in a way, bread and butter of memory services. Any other questions or observations from people? Or if not, I guess there are a couple of themes that seem to keep recurring. One is, I think everybody is saying how important it is to take a thorough history, and actually taking responsibility to at least look at what medication people are taking, and perhaps refer to the list of anticholinergic drugs, and and then highlight it perhaps to a medical colleague if you're not in a position yourself to actually impact on their medication. But it's a very, very simple, quick thing to do, is to identify medication that is causing the cognitive impairment and stop it or substitute it. And it's for everybody's benefit. Michaela, do I see somebody's got their hand up? Yeah, Michaela, yes.
I was just going to say that back in practice, for me, about 10 years ago, we were all going on alcohol-acquired brain injury courses and things. And I was working in an area that was highly deprived. But they were telling us about all of the research across the Wales, different demographics in Wales, and it was the valleys that was the most prevalent. And it was age 40 upwards, really, that there's this massive spike in alcohol. And it's something to be mindful, I think, even through crisis teams, community mental health teams, and with MAD teams. That's what they were telling us at the time.
And I find it sometimes a difficult conversation to have, because I don't know if it's just in Cardiff, but certainly some very respectable, retired, middle-aged people who are knocking back the gin and tonic before the meal and having a bottle of wine with their meal don't take kindly to it being suggested that that's quite a lot of alcohol to be taken.
It was, Tony, because they were telling us that it's steady and often. It's that steady drinking over many years, and we were seeing at that time, because obviously then you can sort of, if you're going on these courses, you can then suddenly spot it, can't you? So many professional people starting to come through with some of these early things that Shami's just been talking about. And it's surprising how many people, even within health service, were suddenly thinking about people they know. So it was hitting professional.
Yeah. And Lisa,
I think there's a role for public health.
I've seen a lot more of it.
Sorry, Shami. Yeah.
I was going to say that there's a role for public health education. Exactly what you said, Tony and Michaela, that people don't realize how much they are drinking, and you know, it's a very difficult conversation to have, because somebody is having, you know, 2 gin and tonics with lunch, and then a glass of whiskey in the evening with dinner. But that in itself is over 5-6 units a day, and it may not look like anything. People may not be intoxicated, but that steady alcohol intake for years and years and years. And again, we get a lot of very high functioning professional people who do that, isn't it? And it's quite embarrassing because that's part of their job. They go here, they have evening parties and they're drinking 3-4 glasses of wine for, you know, but that's well over the limit. So there is a public health aspect to it, which I don't think we highlight enough about actually how much people are drinking without realizing it.
Yeah, no, exactly. Lisa, I think you were highlighting that sometimes it's not so easy to refer to substance misuse services.
Hi, yes, Tony. Yeah, what we see a lot of older adults coming into the service now that have been drinking for quite some time. But the process of referring them to substance misuse services, they have to access sort of counselling, WCADA or Arferiad at the minute, and they don't want to do that. This is before they've seen and assessed them by the community drugs and alcohol team. And when we refer them on, they sort of have a phone call, decline it, and then the case is closed. But by then, you know, they do have sort of some on our caseloads have severe cognitive impairment due to long-term alcohol abuse.
Yeah, no, exactly. And just to highlight that sometimes actually it can be the other way around, that because somebody is developing a dementia, that therefore they haven't got perhaps the memory or the self-control or the executive skills to monitor their alcohol intake. So sometimes high alcohol intake can be a consequence of dementia rather than the other way around. But that's, in a way, back to the history. It's fairly easy to pick it up if you know, the alcohol history is only of the last 1, 2, 3 years. You know, 1, 2, 3 years of drinking is not going to cause you significant cognitive impairment, but we're thinking about more than 10, 15 years or more. Sharmi, you wanted to...
So I just wanted to say, Tony, where I work here, we ring the substance misuse services and we try to get the person an appointment, and we often try to do joint appointments so that, you know, that belts and braces is there in a way. And that sometimes actually works because if they're given, you know, that support is there through the community nurse, but then substance misuse service is able to advise us on what to do and what not to do. So I think joint working is important.
Absolutely, yeah. What we find as well is that the cases are closed, so we revisit that referral and you know, liaise with them to reopen the case again, as you said, because whilst they're drinking, it's not always a priority for them to be seen, and it's about them taking ownership of that and actually wanting to engage as well at the time.
Yeah, no, it's. I think we all agree it's a sort of challenging area that perhaps doesn't always it's not always managed as efficiently and effectively as perhaps it could be. Okay, with that, can I thank Sharmi very, very much for really, I think, what's probably the most difficult presentation to give, because it's covering such a lot of sort of odds and ends, but doing it so effectively. Thank you very much, Sharmi. It's certainly very much appreciated.
Thank you. Thank you.
Okay, if we quickly, Tara, could you just go on to my slides, the vascular dementia slides? I'm sorry if people are having problems with feedback and echo, and so it's probably easiest is, unless you're speaking, if everybody has their mic off, And then if you want to say something, please don't hesitate, but raise your hand, and then we know and can minimize the number of mics on at any one time. Okay, so if my vascular dementia slides are coming, I've specifically left vascular dementia to the last topic because actually vascular dementia on its own is pretty uncommon and rare. On the other hand, it's vastly overdiagnosed. If we go to the, well, let's go to the next slide and perhaps just have an overview of where we are. You said right at the beginning, what we need to think about is, first of all, what's the syndrome? So do they have mild cognitive impairment or dementia? And we're going to gain that from the history. And then do they have other causes of their cognitive impairment, such as those that Shami's just been talking about? And then specifically, if they have dementia, what's the subtype? Recognizing that although on this cartoon, these are all sort of distinct conditions, in practice, it's very common for people to have more than one pathology. In fact, once you get into your 80s and 90s, nearly everybody has a mixed pathology at post-mortem, and perhaps one pathology may be much more significant than another, but need to say there's other things going on as well. Alzheimer's disease is going to be a pathology present in about 60–70% of people with dementia, whereas frontotemporal dementias, which can be due to different pathologies, tau pathology, TDP43 pathology, I think is relatively uncommon. Probably say 2 or 3% of all people with dementia, but as I said before, is in the under 65s, in early onset dementia, is as common or more common than Alzheimer's disease. Lewy body disease, we've talked about, again, underdiagnosed, but perhaps certainly at post-mortem, Lewy body pathology is present in about 30 to 40% of cases, but it's only seems to be contributing to presentation in perhaps 10 or 15%. Those are the people we'd recognise as having dementia with Lewy bodies. So easily missed if we don't think about, ask about sleep, if we don't think about their gait disorder, if we don't inquire about hallucinations. And then we come to vascular dementia or vascular cognitive impairment. So if we go to the next slide, helpfully just pointing out where we are, and the next slide again. Vascular dementia, say, is in community and pathological studies following up people with dementia, it's 4 or 5%, so about 1 in 20 people with dementia is it purely vascular dementia, but mixed vascular and degenerative pathology is very, very common. And again, it's one of these situations where the terminology tends to get very muddled. The easiest way, I think, to think of it is whether it is disease primarily affecting the large blood vessels, so the middle cerebral artery, the anterior cerebral artery, and so on, effectively major stroke disease, or whether it's the smaller arterioles, the small vessel disease, And so the large vessel disease can cause post-stroke dementia or multiple strokes, multi-infarct dementia, whereas the small vessel disease, the official term is actually subcortical ischemic vascular dementia, SIVD. That is the term that is used for research, and in the literature, although it has to be said it's not used much clinically. And small vessel disease can manifest in lots of different ways as small little infarcts. They're just down on the bottom right, cuts from bits of brain, MRI scans of brain, ischemic tissue, so stroke damage shows up white on MRI flare scans. So we can see of those 5, there's a distinct infarct there on first, whereas number 2, there are several small white areas, and that's what would be reported as some white matter disease. Lacunar infarcts and perivascular spaces are just smaller infarcts again, so they're more almost little dots rather than distinct circles. And then visible on MRI, but not visible on CT scans, tiny little microbleeds can also cause problems. So if we go to the next slide, so thinking specifically about small vessel disease, now anybody who has ever looked at a CT scan report or an MRI scan report will know that it's the exception report that doesn't mention small vessel disease, or sometimes it talks about ischemic change or leukoariosis or periventricular white matter changes. It's all the same thing, just using different terminology. But just because there is reported small vessel disease on the scan does not mean that that is the cause of the person's cognitive impairment, because it is so common. And the figure over on the left, the green line for women, the blue line for men, shows that we're already in your 60s, in this large series, are getting on for 60% of people in their 60s are going to have small vessel disease on their scan. I had an MRI scan for research, to help with research as a supposedly normal, healthy control about 18 months ago. And I was slightly upset to find that I had some small vessel changes there, and I had to remind myself that that wasn't necessarily significant, didn't imply that I was cognitively impaired. Certainly once you get into the 70s and 80s, we're up into the 80% that people are going to have small vessel disease. So a small vessel disease report on the scan has to be put into context. And it's only very severe small vessel disease or white matter change that actually is associated with cognitive decline. And interesting, that decline is actually then very slow. The graph at the bottom there, the lines down the bottom is showing the rate of decline on, I think it's mini-mental state in people with Alzheimer's disease. The line at the top, which is more or less horizontal, is normal aging. And the line just below that normal aging line is the rate of decline over a number of years with people who had small vessel disease. It's the average rate of decline with somebody with small vessel disease on mini-mental state is about 0.15 of a point on mini-mental state. So small vessel disease on its own, unless it's severe, is not going to cause major problems. Next slide. Now, there's an MRI scan on the top left there. There is, I think Rachel Brewer mentioned it, there's a thing called the Fasika scale, which is a way of rating the white matter change. And the advantage of MRI FLAIR is that it stands out at you. So there's the Fasika scale goes from 0 to 3. So we've got 0 on the left and 3 over on the right. And it's that severe small vessel disease over on the right that is significant. The scans below are CT scan, and you can actually see this the white small vessel disease on the CT scan, but the problem is it's a dark grey, and so on that bottom left scan we can see the black ventricles in the middle, and then around those black ventricles there's a sort of halo of dark grey, particularly around the top of the ventricles. So that's the sort of periventricular white matter change, small vessel disease that you might see on the CT scan. And when this is significant, it's going to affect particularly attention and slowing of response, and planning and initiation and organisation and sequencing, all those executive problems. So typically it's going to take you 2 or 3 times as long to get through the ACE, because the person may not score that badly, but they'll be so slow, and you lose the power to live while they're actually slowly coming up with the answers. As far as memory is concerned, yes, they have problems with recall, but they, unlike people with Alzheimer's disease, they're often helped by cueing with prompts. And again, if you allow the person long enough, they often might actually recall what they're wanting to say. People talk about lower body Parkinsonism, a sort of shuffling gait, and therefore prone to sort of falls and clumsiness, and sometimes they'll have problems with dysarthria or dysphagia. So that slowing down, in a way, the sort of picture of the caricature of the old man who's very slow physically, very slow speaking, very slow getting to the point. And next slide, it always just gives me an excuse to show this slide that I like. This is the Yalta Conference at the end of the Second World War with Churchill and Roosevelt and Stalin. All 3 of those actually died from a stroke within, well, Churchill managed to last for another 16 or 17 years, but he had his first stroke in about first recognised stroke in about 1948, 1949. And it's interesting just the comments at the time. Say Churchill, this is Lord Moran, who was his personal physician, saying he no longer had a grip on ideas or events. He was not fertile. He was more indifferent to others. It is the sterility of his mind that bothers thoughtful people. The once teeming brain has run dry. And Stalin, laughed at inanities, shallow jokes, failed to get the point of anecdote, talked with difficulty. His pauses between sentences were longer. And in fact, Roosevelt actually had a TIA 2 weeks before the Yalta Conference, but obviously it wasn't good public relations for the world to know that. And so he came to Yalta despite that. But the year before, he seemed strangely tired, sometimes in a haze. He occasionally nodded off during conversation. Once he blacked out halfway through signing his name on a letter, leaving a long scrawl, was not himself the rest of the day. So maybe suggests sort of ischemic event, small TIA. So these three people did not have at the Yalta conference. I think we could be fairly confident that none of them were demented, but certainly there was the suggestion that they weren't as cognitively on the ball as they previously had been. And interestingly, all of them had significant cerebral vascular disease. And so a good example of how small vessel disease can impact on things. So that's small vessel disease, often reported on scans and occasionally when it's severe, clinically relevant. Next slide. As far as large vessel disease, well, this is easier because the person has presented with a stroke or multiple strokes, and therefore typically, the onset has been fairly abrupt. The classical description of a stepwise progression, but that's just reflecting if they have further TIAs or strokes. The cognitive deficits just really depend on where the stroke damage has been done. So they may have particular language problems or problems with spatial problems, and memory may be relatively unaffected. And then there'll be other neurological signs and often mood changes. And on the scan, there are two CT scans there. The CT scan up on the top left, the black area in the sort of frontal temporal area there is of a large stroke, and then there are several areas of stroke damage on the scan below. So the scan showing large vessel strokes are going to imply that this person has at least a vascular element to their condition. But of course, many people with Alzheimer's disease are in fact greater risks of having a stroke. And so again, we're back to the fact that just because they have evidence of large strokes on their scan does not mean that that's the sole cause of their cognitive impairment or their dementia. They may well have, and usually will have, Alzheimer's disease as well. So next slide. Just quickly, as far as managing vascular cognitive impairment, and I'm calling it vascular cognitive impairment because that's a sort of umbrella term for MCI, vascular MCI, like Stalin and Roosevelt and Churchill had at that stage, but also covers dementia. There's actually very limited evidence that anything specifically will help vascular damage to the brain once it's occurred. There may be a very small effect of anti-dementia drugs in pure vascular cognitive impairment, but as I say, because most cases are actually going to have Alzheimer's pathology as well, it may well be that it's appropriate, and NICE will be supportive of considering the drugs. People with vascular cognitive impairment, because they tend to progress more slowly, because they may have some cognitive functions that are relatively unaffected, but may be particularly likely to benefit from cognitive rehabilitative approaches, because you can sort of tap into the skills that people have, and you're not continually trying to stop the tide come in as you are with Alzheimer's disease. The real treatment for vascular dementia is to stop it happening in the first place with primary prevention, and there's evidence that treating hypertension, exercise and stopping smoking, and probably a Mediterranean diet are all associated with less incidence of vascular dementia. But once you actually have vascular dementia, unfortunately, there isn't any great evidence that treating hypertension or taking up exercise or stopping smoking is going to impact on your vascular cognitive impairment, but it is, of course, going to impact on your risk of major stroke and heart attack and peripheral arterial disease. So all the obvious treatments that we would do for somebody who'd had a stroke, we should also be doing for somebody with any element of vascular disease contributing to their dementia, although unfortunately it's not going to have an impact on the course of their dementia. So next slide, please. Okay, that's vascular dementia. Any points anybody wants to raise, or any questions or any queries? If you want to raise your hand or put your mic on and speak, or otherwise, if not, I'll assume that we can move on. Now, I think I said other uncommon dementias. I'm actually only going to talk about 2 uncommon dementias because they're more common than other uncommon dementias, if that makes sense. So I'm going to talk about posterior cortical atrophy and normal pressure hydrocephalus, both of which I think Bijou briefly mentioned. The reason I'm pulling those out is because you know, thinking back, we would see out of say 1,000 referrals to the memory service in Cardiff, we would see perhaps 2, 3, 4, 5 people with posterior cortical atrophy or normal pressure hydrocephalus a year. And they tend to be, all these less common causes of dementia tend to affect younger people, by which I mean people presenting in their 40s, 50s, 60s, and perhaps early 70s. So if we go to posterior cortical atrophy first, and you can see that that's over on the left there under Alzheimer's disease, mainly because Alzheimer's disease is nearly always the underlying pathology. Typically, Alzheimer's disease presents with what's it's called there, the typical amnesic presentation with a memory problem. But if the pathology, instead of first starting in the hippocampus, starts in other parts of the brain, well, it can present in other ways. If it affects the language part of the brain, then it can present as a primary aggressive aphasia, the logopenic variants, or if it's in the frontal lobe, it can present as a frontal dementia, or if it's in the back of the brain, the posterior cortex, then that's what posterior cortical atrophy is. And the next slide, here, this just sums up posterior cortical atrophy. As I say, it's reflecting that the pathological change is going on at the back of the brain in the occipital lobes and the parietal lobes. And that's going to be evident on the scan. There we've got, again, a CT scan showing that the back of the brain, there is significantly more atrophy, wasting, than there is in the middle or the front of the brain. And usually in posterior atrophy, it's symmetrical. Not always, sometimes it can be more one side than the other. But usually the atrophy is symmetrical. And because it's affecting the posterior cortex, the occipital lobes and the parietal lobes, it affects their function. And the occipital lobes tend mainly involved with visual processing, and the parietal lobes are involved with perceptual processing. And so therefore people present with well, examples there: difficulty reading, following the line along the page and going back to the beginning of the next line. Finding these days, when everybody has to use keyboards or with computers or texting, finding a way around the keyboard, knowing where the letter A is and the letter T is. Judging distances. The two commonest presenting symptoms I think I've seen of posterior cortical atrophy. One is people having problems with driving and judging distances. I remember a patient 2 or 3 years ago who had crashed, who had kept on repeatedly having difficulty reversing and going in and out of the drive and hitting the garden wall because they couldn't judge the distances. And then there was another patient a long time ago who used to go to London once a week with work, and they had problems when they got to Paddington Station to go on the Underground because they had great difficulty judging how to get on and off the escalator. And since then, actually, I've asked all people I considered might have posterior cortical atrophy whether they had problems with escalators, and nearly all of them do, to do with that judging distances and perceptual problems. Dressing apraxia, problems telling the clock, and so on. And people often have disproportionate anxiety because otherwise memory, language, executive functions in the early stages are relatively spared, and yet they're having problems with these particular functions. Now, over on the top left are in fact some of the drawings from the ACE, and unless your eyesight's better than mine, you probably can't see them that well, but the clock is over on the top left, which clearly isn't performed very well, and then the two sentences are very unreadable, and the copied drawings are a bit of a mess. And those results are actually of the author Terry Pratchett, who presented with posterior cortical atrophy, and he gives a fairly reasonably typical history in a way, in that he was first diagnosed as probably having had a small stroke, because he was having problems with spatial things. He had problems with his keyboard, using a keyboard, and so he took to dictating his last 2 books to a secretary or using transcription software. And he also had problems with tying a tie, and so he actually took to wearing open neck shirts because he couldn't do a tie on his own. And a year or 2 after this stroke diagnosis, when things were progressing, he was diagnosed with posterior cortical atrophy. He was, which it was explained was a form of Alzheimer's disease. And so when it was announced in the press and everything, it was announced that he had Alzheimer's disease. And for the next 2 or 3, 4 years, he was writing books, he was making television documentaries, he was still very articulate and functioning pretty well. And so people were questioning this Alzheimer's disease diagnosis because he didn't have prominent memory problems or language problems. But then, unfortunately, things inevitably did progress, and for the last 2, 3 years of his life, he had a more typical picture of dementia as the pathology.
Is it just me that's lost connection? No, Tony seems to have vanished.
I got him too. Yeah.
Tony's vanished.
I thought it was just me then.
Tony's disappeared and he's become the man in, was it the man in black? I'll ring him on his phone and see if he's okay. Can anybody hear me?
I can hear you, Michaela, yeah.
Yes, I can hear you.
Right.